Yeah, and with this, we come to our second presentation, which is going to be given by Gordon Cook. And he's addressing real-world insights and clinical experience with BCMA-directed therapies. Gordon, please.
Thank you, Herman. So basically, Mark's very, very expertly nailed all the data from the relevant clinical trials. But I want to really take a look at the populations within these trials and actually see how they relate to what we see in clinic. This is by no means all the clinical trials in the immunotherapy space, but a handful of them. And what you will see from this is that the median age is relatively young compared to what will be your day by day clinical practice. In this population, the high risk genetics are relatively low, as is the EMD. But also relevant to this is ECOG performance status is less than one in the majority of these trials. Prior lines of therapy along the bottom there reflects the fact that these trials were initially used in heavily pretreated patients and then started to move forward. For example, Karma 3, not shown here, Cartitude 4, are in the 1 to 3 prior line range, and then Dream 7 and 8 are in the 1 to 3 prior line range. But of course, what we know from previous years of novel agent clinical trials and now into immunotherapeutic clinical trials is that clinical trial populations represent the best of the best and not necessarily what we see in clinic. And when you do sort of a cross trial sort of analysis with real world populations, you find quite significant disparities. For example, 71% of patients in real world studies would not have been eligible for the Majestic 1 trial, 45% wouldn't be eligible for Cartitude 1, and 75% wouldn't have been eligible for the Karma 3 trial. And that's because we see people who are a bit older, a bit less fit, they have higher performance scores, they have compromised organ function, such as renal function, bone marrow function. And these things are what we deal with week in, week out. And therefore, how these agents work in the real world population is going to be relevant. So I just want to walk you through some of the trial data that Mark has talked about, but in the context of the real world to give you a flavor. So we're going to start with teclistamab. So this is based on just over 200 patients from 9 international centres. And the first thing to say is that the real world data is very biased towards North American health jurisdictions. As time moves on, there will be more and more contribution from European countries as we've all started getting used to these agents after regulatory approval in our own countries. But here, if you look at Majestic 1 overall response rate, the real world response rate is actually pretty decent. It's ever so slightly higher, but effectively it's the same. But one of the things about real world data is that we can actually look at prior BCMA directed therapy usage because generally that was excluded in these earlier immunotherapy trials. And if you look at the overall response rate in people who were prior treated with BCMA directed therapies versus naive, then there is an impact of prior BCMA directed therapy exposure. When I look at the safety, then there is very much comparable, if not slightly better, safety being reported in the real world compared to the clinical trial. Looking at elranatamab, and this is actually a French data set of just over 100 patients. Here, what you see is just ever so slightly a reduction in the overall response rate in real world in purple compared to the magnetism 3 trial in grey. But if you look at the prior BCMA, again, there is a slight drop off in that response rate as we saw with the magnetism, as we saw with teclistamab. Safety profiles, once again, were comparable, but the comment still is significant that these are patients in the real world who had higher ECOG performance status, and therefore the response in such trials compared to the real world is important to take that into context. So when we look at CAR T cells, again, very similar picture. With the real world of using cilta-cel, then the overall response rate is 88% compared to 97% in Cartitude 1. But again, you have to be mindful that in real world, a lot of the people who are receiving this have higher needs and would not have been eligible. Over half the patients in this real world data set would not have been eligible for CARTITUDE-1. As far as PFS and OS is concerned, it's very comforting that actually both the durability of response and survivorship are very comparable with the CARTITUDE-1 trial. In terms of toxicity, it looks like in real world it is actually slightly better than compared to the clinical trial, but some of that may relate to reporting rather than actual. And then when you look at CRS, it's pretty similar, if not slightly less. Looking at ide-cel, again, you're looking at real world in purple and the KARMA study in grey, and you're seeing pretty comparable depth of responses. And then when you're looking at overall response rates, it's almost exactly the same. And once again, you can, with this data, this real world data, almost 160 patients from the US, then when you actually are able to carve up with prior BCMA exposure versus not, so exposed patients are in the grayed out box, 3.2 months versus naive at 9 months, there is a suggestion that prior BCMA exposure does actually have an impact. And one of the things is that we're obviously, as Mark's already elegantly taken us through, the combinational studies with belantamab mafodosin, or belamaf for short, in the relapsed refractory setting. And unfortunately, we don't have enough real world experience to make comment on that. And that is partly because of when these studies were reported, their approvals of regulatory authority, and we will build on that. We will see more data. There was some data at ASH, we will see more data next year. That's been done. There is a lot of real world experience of belamaf monotherapy. And when you look at that in the context of ocular toxicity that Mark introduced, that in the real world, and here we've got the dark blue is Europe and the lighter blue is the US, that when you look at the real world dose modifications, that holding dose is the most common dose modification, 44% in Europe versus 31% in the US. But dose reductions, discontinuations are relatively low, both in Europe and the US. And what this signifies is that as a community, we are becoming more patient focused and flexible about how we deliver the doses. When you look, for example, in the Dream 7, Dream 8, then the median time between doses was somewhere between 8 and 12 weeks. In a trial, you have to perform to the protocol. In real life, then you can have that clinical judgment call that allows you to be more flexible with the dosing. And I think that's one of the key things with belamaf, is that flexible patient-specific, patient-level dosing will actually allow you to manage, if not prevent, the ocular toxicity while maintaining the efficacy in this context. So this is certainly something that we are able to learn from real-world practice. So take-home messages from this is that we are still learning from the real-world delivery of immunotherapies, and real-world patients have a different disease and physical phenotype perspective to those patients in the clinical trials. Clinical trials are the best of the best, and remember that. But the toxicity is surprisingly close between the real world and the trial populations. And therefore, the depth responses are pretty similar. And this is quite comforting that the real world data is highlighting, that these are transferable from trials into our everyday practice. One thing I've not been able to go into, but Mark did introduce it as a concept, is how we prevent and manage infections, the late down the line issues with these agents. That I would highlight Rano Banerjee from Seattle's real world data on preemptive immunoglobulin infusions as opposed to treatment of previous infections with immunoglobulins, and how that affects both PFS and survivorship in that context. As I've already mentioned, real world data about belamaf in combination is still to be delivered because of the sort of delay in getting regulatory approval. But we have learned something about the ocular toxicity management from real world data on using belamaf monotherapy. Now, the big question, of course, is the efficacy of how we are going to sequence treatment. I've shown you a little bit of real world experience where if you have got a prior BCMA exposure, then it does affect depth, if not also durability of responses. And this is something we need to build into, particularly as the immunotherapy agents, which are licensed in the relapsed refractory, are bringing their attention further forward into 1 to 3 prior lines, if not first line.